I'm Adrienne Fu Berman, and I co-direct the Health and the Public Interest program with Dr. Adam Myers now on. And the Health and the Public Interest program is an interdisciplinary master's program where we're aiming to train students to be agents of change in the healthcare world. We really focus on the non-medical um, influences on health, which have become more and more important over the last 3 weeks or so. You can really see the influence of political decisions on health. It's all really important. We're really excited about our speaker today, and I'm going to turn this over to Katie Meadows, our HAPI student, to introduce him.
Hi, thank you all for coming today. So Dr. Paul Offit is the director of the Vaccine Education Center and professor of pediatrics in the Division of Infectious Disease at Children's Hospital of Philadelphia. He's the Maurice R. Hillman Professor of Vaccinology at the Perelman School of Medicine at the University of Pennsylvania. Dr. Offit is an internationally recognized expert in the fields of virology and immunology and was a member of the Advisory Committee on Immunization Practices to the CDC. He's a member of the FDA's Vaccine and Related Biological Products Advisory Committee and is a founding advisory board member of the Autism Science Foundation and the Foundation for Vaccine Research, a member of the Institute of Medicine and co-editor of the foremost vaccine text, Vaccines. He's a recipient of many awards, including the J. Edmund Bradley Prize for Excellence in Pediatrics from the University of Maryland Medical School, the Young Investigator Award in Vaccine Development from the Infectious Disease Society of America, a Research Career Development Award from the National Institutes of Health, and the Sabin Vaccine Institute Gold Medal. Dr. Offit has published in more than 160 papers in medical and scientific journals in the areas of rotavirus-specific immune responses and vaccine safety. He's also the co-inventor of the rotavirus vaccine, RotaTech, recommended for universal use in infants by the CDC. For this achievement, he has received the Luigi Mastriani and William Osler Awards from the University of Pennsylvania School of Medicine and the Charles Miro Award from the National Foundation for Infectious Diseases, and was honored by the Bill and Melinda Gates during their launch of their foundation's Living Proof Project for Global Health. He's received numerous awards and fellowships, as well as being named to the Alpha Omega Alpha Honor Society at the University of Maryland School of Medicine. And as a fun fact, his uncle was Baltimore's biggest bookie before online gambling was a thing. And so now I'll turn it over to Dr. Offit.
Thank you very much for that kind introduction. So what I thought I would talk about is sort of lessons that we've hopefully learned from what happened over the past few years, because I think without question, there has been an enormous loss of trust in public health agencies. And I want to go through at least, I think, some of the reasons for why. So towards the end of 2019, in the southwestern section of the Hunan wholesale seafood market in Wuhan, China, there was an animal to human spillover event, allowing two separate lineages of SARS-CoV-2 to enter the human population. These SARS-CoV-2 viruses were isolated and sequenced in January of 2020, which meant that you now could make a vaccine. Now, typically, a vaccine timeline is it's anywhere from 15 to 25 years. The rotavirus vaccine that I was fortunate enough to be part of at Children's Hospital of Philadelphia took 26 years from sort of research to final product. But usually it goes through a series of phases. Phase 1 trials where you involve 20 to 100 human volunteers, where you try and figure out the right dose, the right dosing interval, the right number of strains, and to make sure that there's not any obvious serious side effect. You then go to several hundred people. Now, in theory, you've got the right amount of antigen, you've got the right number of strains. You have the dosing interval correct. You have the right buffering and stabilizing agent. And here you're looking to make sure there's not, again, a common serious adverse event. And then you go to the definitive trial, the phase 3 trial, prospective, placebo-controlled, usually involves tens of thousands of people and takes several years. For the rotavirus vaccine, that was a 72,000 prospective placebo-controlled trial in 11 countries, took 4 years and probably cost about $350 million. So these are usually a decade or two's worth of work, but nonetheless, with the trial here, it was really 11 months. And primarily, although the research had been done by NIH, really starting in 1997, when Drew Weissman and Katie Carrico were funded to study mRNA as a possible vaccine, for which they eventually won the Nobel Prize in 2023. So that really the research had been done prior to that, but the development program, which was Operation Warp Speed, really put $11 billion into basically 6 companies to win one race. And so it was sort of an unprecedented thing. I'm sorry I didn't label this. That's Donald Trump. So this is it. These were the 6 companies that were funded to make a vaccine. And although people felt that this was way too fast, and I think the naming this as Operation Warp Speed was unfortunate because it sort of suggested that things were going to be done much faster than normal. But really, the 2 trials that were done that were reported to our committee, the FDA's Vaccine Advisory Committee in December, were really typical of any adult or pediatric vaccine trial. So the mRNA vaccine made by Pfizer, and this was a novel technology, but it wasn't novel in the sense that it had been really studied since 1997. And when SARS-1 in 2002, 2003 raised its head, there were in-house people at National Institutes of Health like Barney Graham, Kizzy Corbett, who were already working on an mRNA vaccine for SARS-1. So it really wasn't quite as novel as people feared. But so this was a trial of a little less than 40,000 people, prospective placebo-controlled trial that was done by Pfizer using this novel mRNA technology. And to everyone's surprise, it was 95% effective against all manner of illness, all manner of symptomatic illness, mild, moderate, or severe. I remember Dr. Fauci was talking to us leading up to us being the Vaccine Advisory Committee, hoping that at one point it would be 50% effective and that we should consider approving it or authorizing it if it was 50% effective. Then as we got closer, he thought it might have been 70% effective, but indeed it was about 95% effective. Similarly, the Moderna vaccine, also an mRNA vaccine, was also in this sort of 94 to 95% effective against all manner of symptomatic illness. And so this was surprising, remarkable. At last, it looked like we had a hero for this pandemic, which was going to be the mRNA vaccines. Then comes arguably the harder part, which is vaccinating an entire population, especially when you don't have an infrastructure for mass vaccinating adults. It includes all the things that are shown on this slide. And this is when Joe Biden, who again, sorry, I didn't label, that's Joe Biden there on the left and Jill on the right. And so he really did put in place an infrastructure to mass vaccinate adults for free. So in January of 2021, the vaccine now had been authorized for about a month. After more than 500,000 Americans had died from COVID, the Biden administration immediately began mass producing, mass distributing, and mass administering this vaccine. On the day that President Biden was inaugurated, healthcare workers were vaccinating 1 million Americans every day. 1 month later, in February 2021, it was 1.5 million. In March, it was 2.5 million. In April, 3.5 million. So that by July of 2021, about 70% of the eligible U.S. population had been vaccinated. That is a remarkable achievement. I really do think that in many ways, this was one of the greatest medical or scientific achievements in my lifetime. And I'm old, so my lifetime includes the development of the polio vaccine. Then, however, we hit a wall. About 30% of Americans simply refused to be vaccinated. They didn't want this vaccine, even though it was clear that it worked. It was clear that people were still dying from this virus. They just refused to be vaccinated, as is shown in sort of these headlines around that time. Nearly half of Americans don't trust the CDC and FDA. Health agency have lost the public trust. Public trust in CDC, Dr. Fauci, and other top health officials is evaporating, polls find. So why? What happened? I'm going to go through a few of the possible reasons. One is, I think this is not unique to public health agencies. I think there was a general loss of faith in all federal agencies, in all institutions. So here was a PBS NewsHour Marist poll that was conducted in mid-2021 showing that 41% of Republicans say they do not plan to get vaccinated, whereas 4% of Democrats said that. So this sort of broke down in party lines, as evidenced by this insurrection event that occurred on January 6, 2021. Just this massive sort of disrespect for the federal government. Okay, the second reason I think were the public health measures that were enforced in 2020. Because remember, we didn't have anything in 2020. I mean, hundreds and then thousands of people were dying of COVID. We didn't have antivirals until October. We didn't have monoclonal antibodies until November. We didn't have vaccines until December. All we could do to lessen the impact of this pandemic was to avoid human-to-human contact for a virus that was transmitted asymptomatically. Anybody who you came in contact with could potentially spread to you a virus that could kill you. So what do? We closed businesses, we shuttered schools, we restricted travel, we isolated cases, we insisted on masking and social distancing. And I think for some, these measures were viewed as massive government overreach. I think we leaned into a libertarian left hook in 2020. Then another reason I think was hydroxychloroquine. I don't know if you remember this story, but hydroxychloroquine is an anti-malarial drug that was promoted by a woman named Stella Emanuel, who was part of a right-wing group called America's Frontline Doctors. And she had the ear of Donald Trump. Early in the pandemic, this group, America's Frontline Doctors, conducted a multi-city tour to address what they believed was, quote, a massive disinformation campaign regarding COVID by the federal government. Stella Emanuel, who was a member of that group, explained that nobody needs to get sick. The virus has a cure. It's called hydroxychloroquine. I've treated over 350 patients and not one death. President Trump shared that video of Emanuel's comments to his 84 million Twitter followers, calling it, quote, a must-watch. Quote, I think they are very respected doctors, said Trump. There was a woman who was spectacular, referring to Stella Emanuel. So who was she? She practiced medicine out of a strip mall in Houston, Texas. She was also the founder of the Fire Power Ministries. During her sermon, she preached that alien DNA was used in medical treatments, that scientists were cooking up a vaccine to prevent people from being religious, that cysts, endometriosis, infertility, and miscarriages were caused by women having sex in their dreams with demons and witches, that a witch had concocted a plan to be carried out by the Illuminati to destroy the world using abortion, gay marriage, and children's toys, and that the government is run by reptilians and other aliens who aren't even human. Actually, I'm not sure she's wrong about that last one. Sorry, just kidding. These are the jokes. All right, just don't report me. Okay, so at a White House press conference, when confronted with Emanuel's strange beliefs, Donald Trump didn't back down. Quote, I thought she was very impressive, he said, in the sense that from where she came from, and I don't know what country she comes from, but she said there's been tremendous success with hundreds of different patients, and I thought her voice was an important voice. He was looking for a magic medicine. Here you were in mid-2020, you had nothing, and he wanted a magic medicine to get us out of this pandemic. Hoping to end the pandemic, the administration then bought 29 million doses of hydroxychloroquine, and Donald Trump then twisted the arm of the FDA commissioner, who was then Stephen Hahn, to authorize it for the treatment of COVID, even though there were no data showing that it worked and no data that was safe in this particular indication. So without any evidence that it worked, the FDA authorized the widespread use of this unproven drug to treat coronavirus. Then the studies were done. And there's no reason you couldn't have waited for these studies to be done sooner. So the first was the recovery trial, which was reported in the New England Journal of Medicine. Researchers in the United Kingdom randomly assigned 1,600 patients with COVID to receive hydroxychloroquine plus standard care and 3,200 to receive standard care alone. Patients who received hydroxychloroquine were more likely to need intensive care, more likely to require mechanical ventilation, and more likely to die than those in the standard care group. Hydroxychloroquine not only didn't work, it worsened outcomes. Then there was the coalition trial, which was reported in Lancet. Researchers in Brazil divided 500 patients into three groups. One group received hydroxychloroquine, one received hydroxychloroquine plus azithromycin, an antibiotic which potentiated the effects of hydroxychloroquine, and one received standard care only. Patients receiving hydroxychloroquine with or without azithromycin didn't fare better than those who hadn't received either drug. The only difference was that patients who received hydroxychloroquine were more likely to suffer heart and liver abnormalities because hydroxychloroquine can have a cardiac adverse event. Again, hydroxychloroquine didn't work and was dangerous. Then there was a solidarity trial. These were all done very quickly because COVID was common. This was reported again in the New England Journal of Medicine. Researchers at more than 400 hospitals in 30 countries randomly assigned 900 patients to receive hydroxychloroquine plus standard care and 900 to receive standard care only. Those who received hydroxychloroquine were more likely to develop severe heart arrhythmias and more likely to die than those who received standard care alone. Again, hydroxychloroquine didn't work and was dangerous. This was a massive failure by the FDA. The job of the FDA is to stand between pharmaceutical companies and the American public to make sure that we get drugs that are safe and effective. You can't just bend to the wishes of the executive branch who was looking for a magic medicine. So only 3 months after the hydroxychloroquine had been granted emergency use authorization, they withdrew that approval. So on September 10th, 2020, after that approval had been withdrawn, the Kaiser Family Foundation reported that 62% of adults worried that pressure from the White House could cause the FDA to approve a vaccine before it was ready. Amid the confusion, California, Colorado, Connecticut, Michigan, Nevada, New York, Oregon, Washington, West Virginia, and the District of Columbia formed their own vaccine advisory committees. So I'm on the FDA Vaccine Advisory Committee. They didn't trust us. They felt that the executive branch would twist our arms to do what had just happened with hydroxychloroquine and have that be true with vaccines. Saad Omer, an epidemiologist at Yale, said, quote, "Do you really want a situation where some states are making different decisions than other states?" So in response to this, Stephen Hahn, who was then FDA commissioner, wrote an op-ed in the Washington Post in which he said, quote, "I have been asked repeatedly whether there has been any inappropriate pressure on the FDA to make vaccine decisions that are not based on good data and good science. I have repeatedly said that all FDA decisions have been and will continue to be based solely on good science and data. The public can count on that commitment." And this is just him again saying, sort of in public, that he is not going to shorten the safety follow-up for vaccines. That was my, yeah, sorry. So typically, when vaccine trials are done, you wait 2 months after the last dose to make sure that there's no serious adverse event, because vaccines can have serious adverse events. I mean, the oral polio vaccine is a rare cause of polio. The pandemic's swine flu vaccine used in Europe was a rare cause of narcolepsy. Influenza vaccines can occasionally be a rare cause of Guillain-Barré syndrome. But when that happens, it's invariably based on the immune response to the vaccine, which usually occurs within weeks. So the 2-month safety follow-up is a fair safety follow-up. Now, remember, this is 2020. The election was in November of 2020. If we were going to have a 2-month safety follow-up, that was going to take us into December. And Donald Trump didn't want that. So what he did was he pulled Stephen Hahn into the Oval Office and an invective-laden tirade told him, "You are going to release this vaccine before the election." And to Hahn's credit, he stood up and he didn't do that. He immediately put on his website that there was going to be a 2-month safety follow-up. He did stand up to Donald Trump, who really did try and do the same thing he had done with hydroxychloroquine and do this to the vaccines, but that didn't happen. Okay, reason number 4. Explaining what COVID-19 vaccines can and can't do. This is still a problem, I think, in some people's minds. So you saw the data that were immediately presented to us in December of 2020, where you had excellent protection against all manner of illness, mild, moderate, or severe illness. So 6 months later, protection against severe illness was holding up. As you can see in these 5 studies that were reported, you're still in like the 90% range for protection against severe illness being described as preventing hospitalization, intensive care unit admission, or death. Now, protection against severe illness is mediated in large part by memory B and T cells, which are long-lived. Because, and as is shown here, when you look 6 months later, you still have fairly high frequencies of these memory cells. Because the point is, it takes a while to develop severe illness. This is a short incubation period mucosal infection. The incubation period is the time from when you're exposed to a virus to when you develop symptoms. So you can develop mild symptoms fairly quickly, but it takes a while to develop severe illness. 7 days, 10 days, 14 days. That's plenty of time for activation and differentiation of these memory B cells and memory T cells to become effector cells that then prevent illness. So it's not as hard to prevent severe illness as it is to prevent mild illness. Now, 6 months later, protection against mild illness wasn't holding up. As you see here on the left-hand portion of this slide, that 90% that you saw with 95% with the data that were presented in December of 2020 had fallen to 50%. So protection against mild illness is mediated by high titers of circulating virus neutralizing antibodies, which, as you'll see here, are generally short-lived. So over time, those antibody titers in your circulation will fade. So because virus neutralizing antibodies are short-lived, protection against mild illness will always be short-lived. This is true for all mucosal infections that have short incubation periods. Influenza, respiratory syncytial virus, rotavirus. The goal is to prevent hospitalization. The goal is not to prevent mild disease because you're not going to prevent mild disease for long for these short incubation period infections. For long incubation period infections, like measles, for example, you can eliminate those diseases because mild symptoms won't even develop until 10 days later, 14 days later. So all you need is memory to even prevent mild disease. That's why you can eliminate diseases that have long incubation periods, like measles, which we eliminated in this country in the year 2000, but it's come back because a critical percentage of parents are choosing not to vaccinate their children. We eliminated rubella, another long incubation period disease in 2005. We eliminated polio, another long incubation period disease. We eliminated smallpox, another long incubation period disease. You're never going to eliminate short incubation period diseases. So that's true. Why did the phase 3 trials of mRNA vaccines show such a high level of protection against mild illness? Those data that were presented to us in December of 2020. And the answer is those were 3-month trials. Those patients those participants had just gotten their second dose. So they still had high levels of neutralizing antibodies. And that, I think, was confusing to some people. Right. I think those trials had created an unrealistic expectation of what you could expect from this vaccine in terms of protection against symptomatic illness. And there was probably no better example of that than the Barnstable County outbreak, which occurred in mid-2021. So here was thousands of men went to Provincetown, Massachusetts to celebrate the July 4th holiday. About 346 developed COVID, all of whom had been vaccinated. The vaccination rate at that gathering was around 80%, but here were 346 men who, despite having received 2 doses of vaccine, still got COVID. Now, 4 were hospitalized, which is a hospitalization rate of 1.2%, which is great. That's a vaccine working well. The other 342 had either mild or asymptomatic infections, which unfortunately, the CDC, when they wrote up this in their morbidity and mortality report, used the term breakthrough infections. See, breakthrough implies failure. This wasn't a failure. This was a success. This term is still used, breakthrough infections, and it's an unfortunate one because it gives people the unrealistic expectation that they are going to be protected against all manner of symptomatic illness. I don't know who invented the term sterilizing immunity, but they should be really eliminated from the medical world because there's no such thing. Okay, so breakthrough infections. And I remember I was on CNN and there was you sort of end up waiting about 10 minutes before you actually go on. But there was the segment before mine involved Brett Kavanaugh. And so he had, as a part of a routine screening before entering the Supreme Court chamber, had been tested and found to be asymptomatically positive. If you watch the way CNN carried that story, you would have thought the man was fighting for his life. He had an asymptomatic infection, which they kept referring to as a breakthrough infection. And Lindsey Graham, actually, around the same time, was he too had received 2 doses of vaccine. He too had a mild illness, which was associated with about 2 days worth of sinusitis and upper respiratory tract symptoms. And he said, and I quote, "This would have been much worse had I not been vaccinated." Right. That's exactly right. And I think that we get this with flu. I mean, the messaging around flu vaccine is correct. You're trying to take a wild virus and tame it so that it's a mild virus. That's right. I mean, again, I was part of the rotavirus vaccine trial. We basically eliminated rotavirus hospitalizations in this country with our vaccine, but the virus still circulates in the community, still causes mild disease in the community. Occasionally, we see children come into the emergency department with mild disease, but we basically eliminated the 70,000 hospitalizations. That's a reasonable goal for these vaccines. Okay, another reason for, I think, a loss of trust is vaccine mandates. So when we had a vaccine, by January of 2021, they were mandated for entrance to schools, bars, restaurants, sporting events, and places of worship, among others, hospitals. And it just is, I think we look back on this now, and I think, again, this was leaning into a libertarian left hook. I think people didn't like it. They didn't like it that you had to show your vaccine card to get into places that they wanted to go. And there were some sports figures like Kyrie Irving, who refused to be vaccinated, sort of became a hearing, or Aaron Rodgers sort of refused vaccination, although he said he was immunized but not vaccinated, which was something only he understood because he never got the vaccine. But in any case, this also really upset people, the notion that they had to be vaccinated. Again, this was seen as massive government overreach and has created this sort of rebound where now so many states are considering legislation to ban masking, to ban mandates. And this has spilled over now to school vaccine mandates where people are pushing back on that. And I think that's been a consequence of this pandemic. But just personally, I mean, and I work at a children's hospital, which is going to be less likely overwhelmed than an adult hospital. But in 2021, we were overwhelmed with this virus. We had 3 floors of COVID. We had to make decisions about who could or couldn't go into the intensive care unit. And the fact is, you were 12 times more likely to be hospitalized in 2021 than if you were unvaccinated than if you were vaccinated. Help us out here. I mean, that people perfectly willing to expect us to take care of them, which is certainly understandable, but help us out by at least getting vaccinated. And so in a better world, you wouldn't need mandates. In a better world, people would have access to information that would show that this vaccine was safe and effective, at least as far as we knew in the end of 2020. The Vaccine Advisory Committee read about 800 pages. You got 400 pages to read for each vaccine. And we read every word because you're worried, because you know that you're making a decision for millions of people when you've only looked at data for thousands of people. And so you are worried. You're looking for something in there that worries you. And we all read those 800 pages. I think we were informed consumers. We all got the vaccine. And I wish that the rest of the world saw it the same way that we did. But again, for many, vaccines were seen as government overreach. And this is where we are now, sort of medical freedom. This is the phrase, medical freedom. And at some level, I get it. If you step on a rusty nail and you go to the doctor and you choose not to get a tetanus vaccine that's recommended for you, and you get tetanus, no one's going to catch tetanus from you. It's not a contagious disease. This is a contagious disease. So when you say you don't want to get vaccinated, that it's your right not to get vaccinated. Is it your right to catch and transmit a potentially fatal infection? Remembering that about 10 million people in this country can't be vaccinated because they're getting chemotherapy for their cancers or immune suppressive therapy for their rheumatologic disease. Is that your right to get on an elevator or sit next to someone on a bus who can't be vaccinated? Do you owe them anything? Okay, I think reason number 6 is the confusion about the need for booster dosing. This hasn't gone away. In August of 2021, so now we're in the middle of 2021, President Biden stood up and said, as of September, meaning 1 month hence, the government was going to purchase now a 3rd dose of vaccine for everyone. This upset people. There were 2 people at the FDA, 2 senior people at the FDA, Phil Krause and Marion Gruber, who quit when he made this announcement. Because what he had done is he had gone around the FDA and gone around the CDC and simply declared that there was going to be a 3rd dose. So in September, right before that announcement, right before this 3rd dose was to kick in, Our committee was asked to vote on this, and we voted no. Similarly, the Advisory Committee for Immunization Practices also voted no. So this was also confusing. Here, the president said there's going to be a third dose. These two advisory committees said no. And there were terms that were used at the time by like fully vaccinated or up to date, and it was confusing what it meant to be protected. Okay, so this, I said we rejected that in September of 2021. So in December of 2021, so now we're at the end of 2021, 1 year after vaccines were available, protection against severe disease, remember, which is the goal, was still holding up. This was a paper by Mark Tenford out of the CDC back in the days when they could publish papers. And it showed that it was a study of protection against hospitalization in 8,000 immunocompetent adults between March and December of 2021 who had received 2 doses of mRNA vaccine versus unvaccinated. Median age was 60. 81% of people in that study had one or more medical condition that put them at high risk, and the Delta variant at the time was predominant. And you can see that you're still sort of in the 80, high 80, low 90% range for protection against severe disease. So it was holding up. So we really didn't need that third dose, not then. Then Omicron came into the country, which was a much more evasive strain. And at that point, then a third dose given 4 months later was valuable, but not at that time. Okay, also, now we're at sort of the confusion about the need for yearly booster dosing. We're clearly at a different stage of this pandemic. This is 2022. Most people have been either vaccinated or naturally infected or both. So population immunity is very high. And remember, the goal of the COVID vaccine is to keep people out of the hospital. So the question then becomes, who's getting hospitalized? Who most benefits from a yearly COVID vaccine? So if you look at the CDC's data, the groups that are at highest risk are, 1, people who are over 75 years of age. What Rochelle Walensky, when she was head of the CDC, called the elderly, God bless her. The other thing are people who, as I'm getting closer to 75, those kind of phrases are really appreciated. The other people are people who have high-risk medical conditions like immunosuppression or diabetes, obesity, chronic kidney disease, lung disease, heart disease, neurological disease, people who are pregnant. Those are the high-risk groups. So in the United States and Canada, we're the only ones that currently recommend a COVID vaccine for everyone over 6 months of age, which sort of mimics the flu vaccine. All the other countries pretty much target high-risk groups. The United Kingdom, Germany, France, Sweden, Norway, Finland, Australia, and the World Health Organization recommend targeting booster dosing to those at highest risk. Regarding vaccinating healthy young people, the World Health Organization has stated, quote, although additional booster doses are safe for this group, we do not routinely recommend them given the comparatively low public health returns. So this too has been confusing, I think, for people and has added to the distrust. But the fact is most people don't receive a yearly COVID vaccine. If you look at the right-hand portion of this slide, these are our children. Most children don't get a yearly vaccine. And for children less than 5 years of age, I mean, less than 5% get the vaccine. But remember, children should be vaccinated. Don't walk away from this saying children shouldn't be vaccinated. If you're over 6 months of age and you haven't been vaccinated, you should be vaccinated because roughly 6% of all emergency department visits right now are children less than 5 years of age who are unvaccinated. So vaccinate your children. That's not what we're talking about. We're talking about giving a yearly vaccine to people who aren't at high risk, which is a different story. And you can see even here on the left-hand portion, when you look at adults, even those over 75, even they are less than half get a COVID yearly vaccine. So I think this is actually my last talk, and then I'm open up to any questions you have. 1, don't let politics trump science, which has unfortunately happened. I think the fact is we do learn as we go. This was a novel virus. It had unusual biological characteristics. It had unusual clinical characteristics. I mean, you always learn as you go. And I think we need to make it clear that when we're making decisions based on what's known at the time. I think we have to be careful not to appear too definitive. And it was important for people to be vaccinated. It was important for people to get the vaccine to protect themselves and those around them. But I think we may have been a little heavy-handed in the way that we we characterize this vaccine as being something a little greater than it was. And that when you mandate a vaccine and you know that the vaccine is not likely in 6 months or so to protect against mild to moderate infection, and it's not fun to have a mild or moderate infection. It's not fun to have a couple of days of fever and a hacking cough and miss work. And yet you were mandated to get a vaccine. I think we needed to explain that better. It's always easy in retrospect, though. I think, if you ask people, do you think we're going to know more about science or medicine 10 years from now, 20 years from now than we know now? I think everybody would say yes. But when it comes to sort of your disease, or in this case, our pandemic, people want to believe you know everything you need to know right now, when that's pretty much never true. I think we also shouldn't fear explaining in detail the science that supports or doesn't support a particular policy. I mean, personally, the bivalent vaccine, which was I don't know if you remember the bivalent vaccine. It was that 2-in-1 vaccine where it was a half a dose of the ancestral strain and then a half the dose of Omicron, one of the Omicron subvariants. Because Omicron had come in 2021, the thinking was, all right, why are we still giving the ancestral strain? Let's include the strains that are circulating. So we included the so-called Omicron strain, BA4, BA5. It was half dose of Wuhan, half a dose of BA4, BA5. Those data were presented to our committee in June. Pretty unimpressive. I mean, the immunological data were not impressive. So I was a no vote, as was another member of the committee. And when the clinical data were published, it was also not impressive. The bivalent vaccine was no better than what we had. It was no better than the ancestral strain vaccine, than the monovalent vaccine. It wasn't worse, but it wasn't better. And we kept saying it was better, and that was upsetting to scientists. I don't think the public really understood what was going on with that, but that was upsetting to many scientists, immunologists at the time, who basically called people, like Dr. Fauci and Dr. Walensky and Vivek Murthy and Francis Collins and others, to say, stop saying it's better. It's not better. It's not worse. It's not better. I actually ended up on CNN with Pamela Brown, and then Ashish Jha, who was great. I mean, really very good science communicator, had been saying it was better. They showed a clip of him saying it was better, and then they sort of flipped to me and said, "Well, is he right?" And I said, "Well, here's 2 papers that were just published in the New England Journal of Medicine showing that it's not better. It's not worse, but it's not better." And we shouldn't be afraid of that. I think, of trying to explain what we know and what we don't know at the time. And again, don't be afraid to engage the public in a debate about the science that supports a particular policy. Okay, I think that's all I have. Yeah, that's it. So this is the Vaccine Education Center at our hospital, which you can get all the information you could possibly ever want about vaccines. All right, that's all I have.
Thank you so much, Paul, for a amazingly clear and often first-hand history of vaccines and a little bit about where we are today. I would just wanted to jump in and say that with this large audience, I'm going to ask that people keep their questions short. Paul, you can gauge what's necessary, but we're going to try to get in as many as we can. We're going to start with students, and then after they have gone through their questions, and we'll turn to the general audience. So I now turn it back over to our moderator.
Yes, so we'll start, as Dr. Meyer said, with student questions. So HAPI students, please feel free to raise your hand or put something in the chat. Callie?
All right, thank you so much for coming. This is really interesting. And we were talking about how, politics clearly played a part in people not trusting the vaccine and potentially not getting it. And we're currently in a health communication class, and we've been talking about how just having facts and information does not necessarily mean people are going to change their behavior. So what are some approaches that you think, would have been better to maybe get these distrusting individuals to be more likely to consider the vaccine?
So I think people are compelled by story. I think we have to make this a story and told in a passionate and compassionate way. A choice not to get a vaccine is not a risk-free choice. It's a choice to take a more serious risk. And I think we have to make that come alive. You're right. I think Statistics and facts alone are not persuasive, but I think people are compelled. Well, I'm trying to think of a nicer way to say this. I think we're more compelled by our amygdala than our cerebrum. I think we're compelled more by fear than reason. So I think you need to have both. I think you never leave the science. I mean, that's what you have. That's what separates fear from ignorance. But I think you have to make this much more compelling. I watch my wife sort of dealing with parents who choose not to vaccinate in her practice. She's a private practicing pediatrician in sort of an upper middle class area where there are a lot of people who are making the choice not to vaccinate. And she initially just sort of did the best she could to get people vaccinated. And then she'd had it. She said, look, let me love your child. Don't put me in a position where you're asking me to send this child out of this room not vaccinated, knowing that there's pneumococcus out there, knowing that there's measles out there, knowing there's pertussis out there. I can't do it. I can't do it. And she became much more persuasive that way when she sort of laid it on the line. So I think we're always a little afraid to be emotional, but I think that's part of it.
So now we have a question in the chat from Jackson. He asks, in regards to the evolution of COVID variants like JN1 and KP2, evolution of spike proteins, and the development of multivalent vaccines, how will this new defunding in research affect the evolution rate and spread of potential emerging variant of COVID? There seems to be a lack of worry about the evolving nature of viruses, which could prove detrimental.
Right, or just in general. I mean, how in terms of being able to define whether bird flu starts to spill over into where it's spread from one person to the next. I mean, that and other things. I mean, dengue is starting to become more prevalent. You have actually measles and pertussis are now much more. We've had 5 states that now have measles outbreaks. We've had more pertussis deaths this year than we've had since 2017. And where are the data? Where the data? I mean, I've talked to a friend at the CDC yesterday and said, could you at least hook me into somebody who can provide me with the data about these measles outbreaks? I mean, that's how bad it's gotten. Good point. So I think, though, regarding COVID, I think there's a immunologist at Harvard named Dan Baruch who says it best. T cells are the unsung hero of this pandemic. I mean, the good news is that T cells, like cytotoxic T cells or T helper cells, recognize relatively conserved epitopes. And so those epitopes really haven't changed from the ancestral strain right up to the current strains that are circulating. So, and that they are still going to, especially cytotoxic T cells, are going to still protect you against severe disease. So even though you're going to be less protected, if we never left the original strain, the ancestral strain, you're still probably going to be relatively protected against severe disease. You just won't be as well protected against mild to moderate disease. That's why we make a yearly vaccine. But these viruses are continuing to evolve. So when we sit down in June to pick the COVID strain or strains, really by 5 or 6 months later, often that virus has evolved away from that strain. So, but the good news is hospitalizations are still way down from where they were because of T cells. So if that ever changes, and hopefully we'll have people doing the kind of work to know that it changes, if this virus ever evolves away from T cell recognition, then we're right back to where we were in 2020.
Michaela?
Hi, thank you so much for your presentation. I really enjoyed a lot of the topics discussed. I have a question. It's a little hard, I feel like, to answer, but with recent news and the polarization of our country, specifically in the health space, how do you recommend we build bridges in the sense of creating a sense of trust and try to come back from where we're at currently?
Beats me. I mean, I think things have really drifted away. I think if you look at a reporter asked me recently, did I think that if RFK Jr. was confirmed as head of HHS, and it looks like that meeting is going to be today or tomorrow. Last I heard it was tomorrow morning, but we'll see. Do I think that would cause people to lose trust? I think the opposite is true. I think RFK Jr. is picked because he has disdain for the agency. I think that's true for the head of the FDA. I think it's true for a head of NIH. I think it's going to be true for a head of CDC. They have disdain for the agency, and that's why they're picked. Because I think that the administration is capitalizing on the fact that there's been a tremendous loss of trust in these institutions. And I'm not sure how to get it back, because what I think about to happen over the next few years is you're going to see a deterioration in public health infrastructure. And how will people respond to that? Will they respond to that by saying we made a mistake, we should have trusted these institutions, or not? I don't know, but I am really, really worried. I mean, I think if RFK Jr. is confirmed, and I think that's likely, I think it is a dangerous time to be a child in this country, because I have no doubt he will do everything he can to make vaccines less available and less affordable. And you're already seeing it happen. You're already seeing, 5 states that just have now had measles outbreaks. I mean, we went from roughly 50 cases of measles in 2023 to 280 cases in 2024. And what will it be this year when we've already had 5 outbreaks since only February? I mean, we had 3 outbreaks of measles in 2023. We had 16 outbreaks last year, 2024, and this year I think it's probably going to be even more. So maybe that's the answer, that the only way people will realize the value of public health is when is to see what happens when it gets worse. And I don't know. I mean, I'll give you another example. When I interviewed a guy named Maurice Hilleman, who was in many ways, the father of modern vaccines. He developed 9 of the 14 vaccines that we currently give to infants and young children, including the measles vaccine. That's his vaccine, which he introduced in 1968. He was dying of disseminated cancer in 2004. He was given 6 months to live. So I had known him for 20 years, and he was kind enough to let me interview him so I could write a book about him, which is called Vaccinated. And so now, Andrew Wakefield had published this paper in 1998. Vaccination rates were starting to erode a little with measles. Measles was coming back into our country. And I remember interviewing him, and I said to him, is there any way we can educate people about the importance of getting this vaccine without actually watching children once again suffer? Now, here was a man who devoted his life to making vaccines to prevent that suffering and hospitalization and death. And he spent a long time answering before he would answer that question. I remember it was a snowy day in January in Philadelphia, and he's looking out the back window, and he looks back to me and almost with tears in his eyes and said, no, I think people are once again just going to have to experience these diseases in order to realize how important it is. I think it's not just that we've eliminated measles largely, we've eliminated the memory of measles. And I think that's the problem. So because people aren't scared of the diseases anymore, because people your age didn't grow up with these diseases. I mean, I'm a child of the early 50s. My parents were scared to death of polio. They were scared of measles, which could kill 500 people a year. They were scared of mumps, which was a common cause of acquired deafness. They were scared of rubella, because when a woman got a rubella infection in the first trimester, there was an 85% chance of delivering a child who was blind, deaf, or had heart defects. They were scared of those diseases. Now, people aren't scared of the diseases, so they're much more scared of vaccine safety issues, real or imagined. And I just worry that the only way we're going to get back the trust that we deserve, I think, is to once again see what happens when you tear down the public health infrastructure, because I really think that's what's about to happen. But again, I'm old. See, this is a problem when you have old people speaking. They're always grim.
Francis?
Hi, yeah, thank you so much for speaking. I've really enjoyed what you had to say today. I think you've already begun to speak on what my question is, but I was just thinking about when I was applying for grad school and needing my immunization record and gathering it and realizing that I was overdue for my tetanus vaccine and then getting it and then sending it into the school, and how that process made me realize again how integral schools are for getting everyone to get their vaccines. And so if there's this kind of future that we're looking towards where we're seeing that maybe schools are going to be less likely to be requiring it, and it's going to be more in the hands of pediatricians to be convincing parents to get their children vaccinated. Yeah, I guess, is it just going to be a process in which we're going to have to see these illnesses come back and just learn the hard way? Or I'm just wondering how integral you think the school requirements are to this process of getting children vaccinated.
Well, school requirements are critical. They are. I mean, it wasn't until we really, although school vaccine requirements have been around for many decades, we didn't really start to enforce them till like the 70s and 80s. And that was because there were these massive outbreaks of measles. Because measles is really primary disease of the 5 to 9-year-old, which is school age. It's transmitted in schools. And so you need school vaccine requirements. And I like that. I like your use of the term vaccine requirements instead of mandates, because I think the term mandate does not sit well with people. But if we start to erode those mandates, which I think is in the offing, then you're going to see more disease. I hope you're right that we can educate people enough that they don't have to suffer these diseases. I hope that's true. I mean, we certainly are going to try, but I just worry that the best educator is the disease itself. But I hope I'm wrong.
So it seems that we don't have any more student questions. So I'll now open up the floor to everyone else. Please feel free to raise your hand and wait to be called on before going off mute, or you can put a question in the chat and I will read it out. So we will start with Jacob Rich.
Hi, Dr. Offit. Thank you so much for that presentation. It's a pleasure to actually get to talk to you today. I'm a student at Case Western studying epidemiology and biostats. And when I kind of want to bring this back to Aaron Rodgers real quick, when he said that he was immunized, his argument was that he had already caught COVID and that gave him some sort of protection, right? Now, a lot of studies have come out and shown that prior infection might not be as effective as the COVID vaccine itself. But there was a study that came out in MMWR by, I think it was Boys et al. And it was out in 2021. And it said that the vaccine was 5 times more effective than prior infection. And just by looking at that number in the headlines, it seems like that could not quite be possible. Like if you have like a 100% effective vaccine, that means prior infection is only 20%. Now the study was looking at relative risk of odd ratios, not absolute risk, but it's still like a massive, massive difference. So is there any responsibility on public health officials and researchers to re-examine prior studies that influenced policy and to comment and correct what was done before in order to gain the public's trust?
Okay, a couple things. First of all, Aaron Rodgers, when he said that he had been immunized and but not vaccinated, at least one of the things that he offered was he had taken some sort of unusual homeopathic remedy that he felt protected him. But and also, by the way, just because I don't want to let this go by, go Birds, huh? Was that a great game? All right, just moving on. So I'm a Philadelphia Eagles season ticket holder. No, you're right. I mean, I think the question is, does natural infection protect against severe disease associated with re-exposure? Yes, I think there were a number of studies that showed that. And you will be interested to hear that in February of 2022, there was a meeting, which unfortunately was not a meeting open to the public, but I think should have been, with Drs. Fauci and Walensky and Francis Collins, when he was still head of NIH, and Vivek Murthy, U.S. Surgeon General then, to ask the question, should natural infection count as vaccination? In other words, should people who have who are now mandated to receive a vaccine, can they reasonably say, look, I've been naturally infected? Shouldn't that count as a vaccine? I don't think I need to get a vaccine anymore. So there were 4 of us that were asked to be part of that, me and 3 other sort of viral immunology types. And I voted yes, that I think natural infection should count. I was outvoted, but I certainly agree with you, because in many ways you can argue when you're naturally infected, assuming you live. So this is a downside of natural infection, is that you may die trying to get it. But you'll get an immune response to all 4 viral proteins. Not and in many ways a more vigorous response against other sort of T cell epitopes that are not on that fusion protein. So sure, I agree with you. I think that should have been. I think for bureaucratic reasons more than anything else, it wasn't done. Meaning it's pretty easy to show that you were naturally infected. Just print something off the internet, and they were trying to make sure people got. But I agree with you. I think that's one. It's a conversation that should have happened in public, and 2, I think that natural infection should have counted. So I completely agree with you.
Thank you, Dr. Offit.
Sure.
Professor Berman.
I love you, Paul. I love your research. I love your communication style, but also your wry sense of humor. I don't think you're grim at all. But your sense of nuance is actually so important here, and I think it's been demonstrated by your answers to these questions. And do you think that like part of the problem with our public health messaging around COVID was were these sort of blanket recommendations that were made without taking into consideration some of this nuance, like if you've been previously infected, maybe the vaccine isn't going to do anything for you, or maybe we don't have to wear masks outside, which was actually pretty well known within a few months of the epidemic. Like a key part of public health messaging is keep it simple. And did that lose people when we did these kinds of blanket recommendations?
Yes, I completely agree with that. And I think that now, for example, I asked a major public health official, because very, very soon after, well, I was really very early on saying I don't think everybody needs a yearly vaccine, that we should target high-risk groups, as most other countries did. And I got a lot of pushback from public health people. And one prominent public health person, I went up and I said, am I wrong? Am I wrong to say we should target high-risk groups? And he said, no, you're right. I think that's what we should do. But by saying we should vaccinate everybody, that makes it more likely that high-risk groups will be vaccinated. First of all, I'm not sure that's true. And secondly, trust the American public to do this, because we certainly have other targeted recommendations for other vaccines. I mean, this would not be unique to this vaccine. And I think you're right. I think the thinking of this particular person I talked to was, that a nuanced message is a garbled message, but I don't think that's true. I think it's incumbent upon us to make that case, because why should a healthy 18-year-old get a yearly dose when they aren't going to benefit much from it? What they'll benefit from is they'll get about 4 to 6 months better protection against mild to moderate disease for that period of time. But that's really not the goal of the vaccine. It's to keep you out of the hospital. And I think we should trust the American public to try and explain that, knowing that we're going to lose some people, but at least give it a shot, so to speak.
Thank you.
Mr. Callahan?
Yeah, hi, Dr. Offit. Yeah, I formerly worked at the FDA, and I recently retired. There was a little bit of evidence that hydroxychloroquine wouldn't work even before the EUA was done. When we looked at lupus patients, they were getting infected and hospitalized at the same rate as normal people, and yet the FDA still went on and gave the EUA. I mean, I presented that data to people at the FDA when I worked there, and we still went ahead. But the thing I wanted to ask you about was the Cuban vaccines. I mean, Cuba designed, I think, what are really rationally designed vaccines, where they just have the receptor binding domain, and they, one of them they passed the tetanus toxoid to sort of boost your T cell immunity. They've reported no COVID deaths for over 3 or 4 years, for almost 3 years now, or 2.5. And very low infection rates. And, I don't know if they've boosted with other vaccines. They had a 3-dose regimen, and it seems to be very effective. And they seem to be much better rationally designed. I mean, the mRNA vaccines don't seem to be that good, to be honest with you. I mean, look, and other people at FDA, I think, concur with that. They did save lives. There's no question about that. But I mean, the whole spike protein, they found out that most of the antibodies are directed to areas outside the receptor binding domain. And they also bring an IgG4 response, which then you lose ADCC. So, I mean, these, for some reason, weren't great vaccines. And it was a shame that, they were jumped on and the protein vaccines were kind of slow pedaled.
So I'm not sure I agree with everything you said. I do think the mRNA vaccines were of tremendous value, and I did. So for example, Peter Hotez at Baylor University developed a receptor binding domain vaccine, which was introduced in an mRNA receptor binding domain vaccine, which was introduced into India. It's not clear to me that that was better in the sense that when you just look at the receptor binding domain, you are losing critical T cell epitopes by not having that whole fusion protein. So I don't know if you ever listened to This Week in Virology with Vincent Racaniello.
Yeah, I do. Yeah.
So they were never big fans of the receptor binding domain vaccine. But in any case, I certainly.
But if you look at the Cuban data, though, I mean, it looks unbelievable. Is it unbelievable, or is it true? I mean, where they haven't, they have single-digit infection rates in Cuba. Nobody's died. I mean, and again, these were protein vaccines, not mRNA vaccines, because the mRNA vaccines tend to prejudice it.
Yeah, I mean, and are the data we're getting good? I mean, are the data we're getting out of Cuban good, or is Cuba to some extent a black box, as China was, as India is at some level with regard to their statistics? And it's I guess I'm always a little worried when people say nobody died. I mean, it's like,
well, from COVID.
Right.
Yeah.
All right. So, well, in any case, I certainly agree with you that there's much more to learn about how to make a better vaccine. That I agree with.
Miss Hay?
Hello, Dr. Offit. Thank you so much for your presentation. It's highly informative and wonderful. So I am looking to pursue a doctoral degree in public health. I wonder if Georgetown University offers such program?
So I'm not the person to ask that question to. I guess Adrian is the person to answer that question.
Adrian, you're on mute.
I'm sorry, was the question whether we have a public health program?
A PhD program in public health.
No, we don't have a public health school. There's a PhD program in epidemiology, and we have the master's program in health and the public interest and other health related fields, but we don't have a PhD in public health.
Got it. Thank you.
If you have any more questions, please, again, feel free to raise your hand or put them in the chat. I guess for now, Dr. Offit, I was wondering if you could go back and change one thing about the COVID messaging. And I know that that's a very hard question, but if there was like one change that you think you could make, what do you think that would be?
I think that in December of 2020, when those two vaccines were Pfizer and Moderna's vaccines were reported as being 94 to 95% effective against all manner of illness, you knew it was a short incubation period, the virus. You knew that. You knew that antibodies were mediating protection against mild to moderate disease. You knew those were 3-month studies. You know people had just gotten a second dose. You knew that wasn't going to hold up. We should have let people know right then what to expect from this vaccine. That while you may be mandated to get this vaccine, you may not be protected against mild to moderate disease. The goal is to keep you out of the hospital, because I think people didn't get that. And I think that's part of what made people so angry. But that would be the one thing I would change. But I unfortunately have to go because I have put something at at least 1 o'clock my time.
Okay, if Dr. Offit has to go, Katie, can you just close us out?
Yeah.
Yes. So thank you all for attending this today. I believe it's recorded and will be sent out if that is something that you are looking for. We have seminars every week, so please feel free to visit the HAPI website and see what else we have coming up for the rest of the semester. Thank you for joining us.
I'd like to
you so
just add
much.
to that real quickly, my thanks. And I also want to point out that through our website, which is hapi.georgetown.edu, you can access our previous seminars, which include Peter Hotez and many other folks who have talked about COVID and related matters. But this is really a highlight of our seminar series this year. And I thank you very much, Paul.
Thank you. Thanks for asking me.